Welcome. In this lecture, we'll be discussing status epilepticus. Status epilepticus can be defined two ways: a continuous seizure activity lasting greater than 5 minutes, or two or more seizures without regaining consciousness. This definition is important to know for your exam day. Now, typically, SE can be any seizure subtype, but for the purpose of exams, it will generally be a tonic-clonic or convulsive-like seizure. Understanding the pathology is also important. SE is a prolonged seizure state caused by a failure of normal inhibitory mechanisms in the brain. The pathophysiology involves an early phase dominated by excessive excitatory neurotransmission, or uncontrolled neuronal excitation. We typically see this as an increase in glutamate release, which is your primary central nervous system excitatory neurotransmitter. At the same time, inhibitory GABAergic activity decreases, or we have a reduced neuronal inhibition, or we cannot turn off cells. We see this as a decreased GABA release, which is your primary CNS inhibitory neurotransmitter. This is partly because GABA A receptors become internalized and less responsive over time the longer the seizure lasts. Now, prolonged seizure activity leads to metabolic stress and neuronal injury. Excessive calcium influx, mitochondrial dysfunction, and even oxidative stress contributes to excitotoxicity, damaging neurons. We can see this in the diagram below as we have an increase in glutamate release and a decrease in GABAergic activity. This leads to self-sustaining seizures, but systemically, SE can cause a multitude of different problems, such as hypoxia, acidosis, hypothermia, muscle breakdown leading to rhabdomyolysis, and autonomic instability, which can further exacerbate brain damage. The longer the seizure continues, the higher the risk of complications and mortality. Thus, it is important to identify and treat status epilepticus as soon as possible. Now, SE can either be an initial presentation, aka a first-time seizure, or it can be in someone with known seizure who's on anti-epileptics or has a history of epilepsy. Now, the most common cause in a patient with a known history is poor medication adherence. An individual who fails to take their medications appropriately or fails to refill their medications. Now, we can also see another common cause, typically in older individuals above the age of 60, as stroke is one of the most common causes of new onset seizures in older individuals. Now, there are other multitude of different things that can cause status epilepticus, and a mnemonic to remember that is Status EP, where S stands for stroke, especially in individuals above 60, T for trauma or traumatic brain injury, A for alcohol withdrawal, T for tumors, U for underdose of anti-epileptics or individuals who have poor medication adherence, S for sepsis, infections, meningitis, E for electrolyte issues, hypoglycemia, hypocalcemia, etc., P for poisoning or drug overdose. Now, as you know, there are a lot of different things that can cause SE, but the two you need to know for exam day is poor medication adherence and new onset stroke. Now, it is also important to have an appropriate approach to SE. Patients, again, can present anyway with status epilepticus, but for exam purposes, will typically present to the ED with tonic-clonic-like convulsions. Now, a mnemonic to remember the stepwise approaches is with ABCDG, where ABC stands for airway, breathing, circulation. You want to make sure that these individuals are protecting their airway. Do they need to be intubated? D stands for drugs. What drugs should we treat these individuals with, which we will go over shortly. And then G for glucose. And this is the most important to remember. Everyone who presents with a seizure should have a finger stick checked. If they are hypoglycemic, especially severe hypoglycemic, this can mimic SE and can cause prolonged altered consciousness, jerking movements, unresponsiveness. We always check a finger stick glucose first, and if they're hypoglycemic, we will treat them by raising their blood sugar. We do this before any other medications are given. Now, treatment is stepwise. The gold standard in SE as a first-line medication is always going to be a short-acting benzodiazepine. Typically, you'll see lorazepam or diazepam given. Sometimes even midazolam can be given. These are the frontline treatment for terminating ongoing seizures, with lorazepam being the most commonly used due to its rapid onset of action. And lorazepam is actually preferred over diazepam in the clinical setting because of its comparatively longer half-life. For the purposes of exams, you should not have to choose between the two of them. Now, if benzos do not work, the next line medication is going to be one of these four: phosphenytoin, phenytoin, valproate or valproic acid, or levetiracetam, also known as Keppra. Now, actually, out of the four, phosphenytoin is actually preferable due to its quicker infusion rate and lower risk of side effects and cardiovascular issues. But, again, you should not have to be choosing between the four of these on exam day. If both the first line and the second line fail, this is actually known as refractory status epilepticus. With these cases, patients should undergo intubation, if not already performed, and be treated with either propofol or midazolam infusions. If the seizures continue to persist despite continuous infusion of these propofol or midazolam, the next course of action is actually to induce a barbiturate coma. And we do this with pentobarbital. This is essentially turning off the central nervous system and then rebooting it. Just like if you were to have a laggy phone, you would shut it off and then turn it back on, and hopefully that would solve the lagginess behind it. The same exact concept is done here. That will always be your last resort. Now let's go through this as an algorithm. So let's say we have someone who meets our criteria for SE. Seizures are greater than 5 minutes, or we have 2 or more seizures without returning to baseline or consciousness. Once we meet this criteria, we follow our ABCDGs. Airway, breathing, circulation. We want to make sure that this individual is protecting their airway. Of note, typically people are not intubated right away when they come in with status epilepticus. We always try and treat the underlying cause first. We always want to check a glucose, and if they're hypoglycemic, then we reverse. Remember, we do this before any other treatment. And then, of course, we want to gain IV access, and we would give our first-line medications if they are not hypoglycemic and they don't need to be intubated. With that, we either give our lorazepam or our diazepam. If this fails, we would then administer our second-line medications: phosphenytoin, phenytoin, valproate, or levetiracetam. Next, if this fails, we have refractory status epilepticus. This individual needs to be intubated and they need to be placed on an infusion. If they are still seizing, then we put them in a drug-induced coma with pentobarbital. It is extremely important for the purposes of your exams to know this stepwise procedure, as this will be the most common concept for SE that you will be tested on. Now, with people with SE, what exactly do we do once we take care of their status epilepticus? Well, if an individual has a history of epilepsy or they're on medications, realistically, there's not really much for us to do. Most likely, this is actually secondary to non-adherence, and in that case, we can check an anti-seizure level. Whatever medications they're supposed to be on, Keppra, valproate, lamotrigine, lacosamide, all these other anti-seizure medications, we can check their level and to see, are they actually at therapeutic range or therapeutic value. In some cases, it would be appropriate to check for electrolytes and to replete, such as calcium, phosphorus, magnesium, etc. Now, let's say an individual presents with a first-time seizure, or they present when they're extremely old, like above 60, 70, 65, etc. In this case, we typically actually want to get a CT scan. And what we're looking for here is a stroke. And the reason being is because this is the most common cause of SE in individuals above the age of 60. And that's how you'll know for your exams. For clinical scenario, for real life clinical practice, EEG is not always indicated for SE patients. But sometimes this is actually done as some individuals can have what is known as subclinical seizures. Seizures that actually do not present with those typical tonic-clonic convulsions. As I mentioned before, SE can present with any seizure subtype. But for the purposes of your exams, typically they may be asking you to get a CT scan to look for stroke if it's a first-time seizure in an older individual. Be aware of that for your exams. Now, what is the best prophylaxis therapy? Individuals who have status epilepticus need to have prevention therapy to prevent another reoccurrence. The best and first-line medication is phenytoin. Now, the mechanism of action is important to know, as this is a sodium channel blocker. You should understand that a lot of these anti-seizure medications are sodium channel blockers, but phenytoin falls in that category. But where they may go on exams, especially for all the other anti-epileptics, is to understand the adverse effects. Now, the adverse effects of phenytoin will be ataxia, diplopia, or double vision. It can break down bones, osteopenia, and you may also see gingival hyperplasia, or thickening of your gingival line or your gums. This is very unique presentation for phenytoin and something that you should be on the lookout for test day. You may also get a very, very rare syndrome known as DRESS syndrome, where D stands for drugs. The drugs that can cause this are allopurinol, phenytoin, and carbamazepine. R is your drug reaction, so you get a rash. E stands for eosinophilia, and S stands for systemic symptoms. Usually, this will be something known as a morbilliform rash, which I'll demonstrate. That's a very classic drug-like rash pattern. Elevated liver enzymes, so elevated AST, ALT. You may see diffuse lymphadenopathy, and of course, eosinophilia. This is what a morbilliform rash, or a drug-like rash, looks like. Kind of patchy, spotty all over. Now, phenytoin, which I've not included on this slide, can also cause Stevens-Johnson syndrome and other abnormalities as well. But for the purposes of your exams, DRESS syndrome, which is really only caused by one of those three medications, would most likely be higher yield. It is also important to know that phenytoin is teratogenic, and it can cause something known as fetal hydration or hydrotion syndrome, where this typically presents with a newborn with a small head, nail hypoplasia or breakdown of the nails, very thin nails, maybe lack of nails even, cleft palate, and wide-spaced eyes, or even narrow eyes. Now, if you have signs of any type of toxicity, or an individual who's on phenytoin, for whatever reason, tonic-clonic seizures or SE, and they want to get pregnant, it is important to know for phenytoin, we never, and for a lot of the anti-epileptics, we never abruptly stop these medications, as that increases your risk for breakthrough seizures. Instead, we always slowly taper these medications, and that is extremely important to know for exam day. Now, let's go over some practice questions. Pause the video and try your best to answer this. Now, the correct answer here is B. This patient is in status epilepticus. Remember, this is defined as a seizure greater than 5 minutes of continuous seizure or multiple seizures, 2 or more, without recovery of consciousness. He already received the first-line benzodiazepine here, right? He already received first-line medication. So the next step is the second-line treatment with a longer-acting anti-epileptic drug like phosphophenytoin, levetiracetam, phenytoin, valproate, something like that. The second-line medication here would be IV phosphatidone. Let's do one more question. Pause the video and try your best answer. The best answer here is going to be D. In any altered or seizing patient, hypoglycemia must be ruled out immediately, as it is a rapidly reversible and it can also be potentially life-threatening cause that can mimic or even trigger seizures. Thus, a finger stick glucose should always be done on the first steps in emergency seizure evaluation. If you also, just because this is a lecture on SE, this person does not meet criteria for SE, as this seizure has only been ongoing for 2 minutes and has no other seizure activity. Thus, there's no indication to treat this as it is status epilepticus. Many seizures actually self-resolve within 2 to 3 minutes without treatment. But still, we always check a glucose on all of those individuals. And that concludes this lecture on status epilepticus.